Hello. Hello. Are you able to hear me?
Hello. Hello. Yes.
Okay. Okay. That's great, right? So today we are going to start our pathology. We already have started that, but the topic which we are going to discuss today is rickets, osteomalacia. Along with that, we are also going to discuss some of important topic that is osteoporosis, and along with that, we are also going to discuss some MCQs as well, right? Okay. So let me just share my screen. Uh, can you guys just see my screen? Hello.
Yes. Yes.
Okay. Okay. That's great. Right. So the first pathology which we are going to discuss today is rickets and osteomalacia. Okay. Before discussing this topic, you guys should know two things, right? That's the basic thing which we keep on discussing again and again. So we have our osteoblasts and we have our osteoclasts, right? We know that the osteoblasts are basically involved in formation of your bone, and osteoclasts are basically involved in destruction of your bone, right? We know that. Okay. We also know that osteoblasts work whenever the environment around it is alkaline, right? So it would work in alkaline environment, or in other words, if we have alkaline environment, it would more favor to form or to increase the activity of your osteoblast. On the other hand, we discussed that osteoclasts basically work in acidic environment, right? Like, or in other words, we can say whenever we have acidic environment, or it would just favor more activity of your osteoblast to occur. Okay. Okay. Remember, how does the osteoblast just lay down bone? That's really important and really simple mechanism. Osteoblasts first are going to, lay down something called osteoids, right? Osteoids. So osteoids are going to be, like, you can simply imagine it's an immature kind of matrix, which is the building particle or the building material for your for your bone. And then with time you have to calcify it, right? You have to lay down calcium on it, phosphate, in order to strengthen the osteoid. That's the normal process of your bone formation, right? Okay, we discussed in our renal section in detail that how does the calcium works, right? How does we have calcium? So if you guys remember the significance of vitamin D, do you guys remember that? Vitamin D. Okay. We discussed that how can we get vitamin D? Vitamin D can be obtained from dietary resource, or whenever the sunlight falls on your skin. We know that it's going to make the precursor. That's going to be 25 hydroxylation of that is going to occur in liver. Then in your renal or in your proximal convoluted tubule, if you remember, we have an enzyme. What's the name of that? 1-alpha hydroxylase. Remember, which is going to
Yes.
further
Yes.
hydroxylate it into 125 OH calcitriol or calciferol, which is basically an activated form of vitamin D, right? We also discussed the 1-alpha hydroxylase in activity in non-caseating granulomas. Did you remember? Non-caseating
Yes, sir.
granuloma, which
Yes.
conditions? Sarcoidosis, remember?
Sarcoidosis. Yeah.
Going to lead to, in sarcoidosis we have hypercalcemia. Why? Because it's going to increase, the macrophages basically have, granulomas are basically macrophages, right, which are surrounding any particle which they cannot eat. They are going to make a wall around of a wall around it. So whenever we have non-caseating granulomas, is going to be having a lot of 1-alpha hydroxylase activity, which can lead to hypercalcemia as well. One of your world MCQ, right? So as we have activated form of vitamin D, what this vitamin D is going to do? It's going to act on where? It's going to act on your
On your intestine to
Intestine.
absorb
Yeah.
the
in
It's
calcium
order to
absorb the
and
calcium.
phosphate from the
in order to
Intestine.
blood.
reabsorb your
Calcium
calcium
and
Calcium.
phosphate.
and phosphate. Perfect, right? So this was the entire mechanism. We also discussed that how can further reabsorption of calcium occurs. PTH acting on your bone. It can increase the calcium level of your blood, right? It can just destroy your bone. Uh, you know, activating your osteoclast furtherly, it can lead to you know increase calcium in your bone, if you remember, right? I'm just discussing the calcium homeostasis. Okay. The third thing was PTH was also directly acting on which tubule? Distal convoluted tubule, which lead to reabsorption of your calcium, if you remember, right? So this calcium is basically really important for what we discussed. in order to strengthen your osteoid. Am I right?
Yes.
Yes.
Okay. So for example, those individuals who do not have proper sun exposure, it means it would lead to decreased vitamin D. Am I right? Hello?
Yes, doctor.
It lead to
Yes.
decreased calcium. Can I say that? Hello?
Yes,
And
yes,
still
yes.
they have decreased dietary intake of vitamin D. Again, they can lead to
Mm.
less calcium, right?
Less calcium.
Okay.
Yes.
Which signs are associated with hypocalcemia? Really important.
Tetany,
Tetany and
Jovistic and
And
Jovistic and
Tosia and
Trozio.
Tovistic sign.
Shostak sign.
Yes.
Why? Because you know that calcium is basically inhibitor of your Na channel. So if you have less calcium, so it means a lot of Na would just flow into the cell. It would lead to a lot of depolarization, resulting in tetany, right? Okay, we know that. This is only the revision which we already discussed in our endocrine, in our renal collectively, right? But for example, if in the children we do not have sufficient vitamin D, right? Due to any reasons, okay? Like similarly, renal failure can also lead to hypocalcemia. Why? Because if we have renal failure, no activity of one alpha hydroxylate, it means no activated vitamin D. And if you do not have activated vitamin D, again, it's going to lead to hypocalcemia. So if we have less calcium, can we strengthen osteoid? Yes or no?
No.
Okay, we cannot strengthen the osteoid. It
No.
means that the bone is going to be really weak and a kind of really flexible, right? Okay. Hello? So if we have vitamin
Yes,
D
doctor.
deficiency in children, right, it's going to lead to pathology of bone, which is called as rickets. If we have vitamin D deficiency in mature people, it's going to again lead to a bone pathology, which is known as osteomalacia, right? So rickets and osteomalacia, both of them are due to, same cause, that is decreased vitamin D, less calcium, less mineralization of your osteoid. But if it's in children, it's going to be called as rickets. If it's in mature people or, in adolescents, so it's going to be called as osteomalacia. Is it clear? Hello? Okay, so for
Yes.
example, if we
Yes,
have
doctor.
osteoid that isn't, we already discussed, you cannot calcify it, it's going to be really weak. So what are we going to see? What are going to be the, classical symptoms or appearance of an individual having this condition? First of all, if it's in children, if it's, in less than 1 year of child, so it's going to appear as, okay, we are going to be having pigeon breast deformity. What do we mean by pigeon breast deformity? You're going to be having inward bending of the ribs and anterior protrusion of the sternum would just appear as a pigeon
Yes.
breast, right? Okay, that's really characteristics of rickets, right? What else? We are going to be having frontal bossing. What is frontal bossing? No, your frontal bone is going to be having a lot of osteoid on its surface. So a lot of osteoid, like you can simply think of, you have osteoid being produced by your osteoblasts, but it cannot be mineralized. Still your body need mineralized osteoid. So your osteoblasts are going to make a lot of osteoid. They are going to give an attempt in order to have a proper bone. But since the problem is with vitamin D, the problem is with decreased calcium, so your osteoblast is going to be making a lot of osteoid without its mineralization, right? So this osteoid deposition on your frontal bone can in the babies or in the child, frontal bone can appear as frontal bossing, right? Frontal bossing. What else? We can have a lot of osteoid deposition in costochondral junction as well, right? On costochondral junction as well. And it would just appear as a rachitic rosary. Do you know what is a rosary? No? It's basically, what can I say? The one which people use to, say some, do some zikr, right? That is like, monks also used to repeat some, some of their, yes,
Tasbih?
religious, their tasbih. You know what is tasbih? Okay. Some people know them,
Yes.
some of people do not know them, right? So it's going to appear as a beads, a ground kind of beads, just as a rosary, right? So that is basically called as rachitic rosary. As these beads are, small round spherical beads, right? on your costochondral junction. So that's going to be called as rosary, rachitic rosary. Why? Because it's seen in the rickets, which is due to deposition of osteoids there, right, in costochondral junction. Is it clear? And as we know that osteoids are really weak, so once we have osteoid deposition of the legs, as these osteoids are going to be really flexible, so the legs are going to be bowed, right? So a child with this condition is going to be having bowing of legs, right? Bowing of legs. Is it clear? Okay. We discussed if the same vitamin D deficiency is seen in adults, the name is going to be changed. That's going to be osteomalacia. Okay. Osteomalacia. Okay, so it's again due to inadequate mineralization, having a weak bone. What are going to be the lab findings? Yes, the calcium is going to be really low. If the calcium is low, what would happen to PTH as a result of that? We discussed it in detail.
High. Will be high.
Loss of that feedback inhibition. Okay, what will happen to the serum phosphate if we have less vitamin D? If you have less vitamin D and more PTH,
it will decrease as well.
Yes.
yeah, because it's a phosphate trashing hormone, right? Right, increased PTH is going to trash a lot of phosphate, so the serum phosphate is going to be really less. Okay, what's going to happen to alkaline phosphatase? Yes,
It's become high.
It will increase.
it become high. Why it become high? Because we discussed that here we are going to be having a lot of activity of your osteoblast,
Osteoblast activity. Yeah.
right? Osteoblast activity is going to be increased, which is going to lay down a lot of
Osteoid.
osteoid, right? And osteoblasts act in which environment? In alkaline environment. So alkaline phosphatase is going to be really high. Is it clear?
Yes.
Okay, so this was all about rickets and osteomalacia. Okay, so let's discuss our next topic, that is osteoporosis, right? Osteoporosis. Okay, what is osteoporosis? Remember, in order to have a proper understanding of osteoporosis, you should know what is peak bone mass. Peak bone mass. As the name indicates, in our life, okay, till which age do our bone become, mature, like highly mature, mature till its end? That's a peak bone mass. At 30 years of age, basically your bone get mature. That's the hardest and the more strengthened bone which you can have throughout your life, right? That's your peak bone mass, which basically is, the age for having a proper peak bone mass of an individual is 30 years of age. Is it clear? Okay, which factors are important in order to increase your peak bone mass? So there are three factors. The first one is genetics,
Exercise.
right? If you have good genetics for your bone, you're going to be having a great peak bone mass at 30 years of your age, right? Okay, the other one is exercise. If you're exercising more, you're going to be having, really great peak bone mass at 30 years of your age. Other thing is intake of vitamin D, right? If you have proper intake of vitamin D, the peak bone mass is going to be really great. You're going to have a really good quality of bone at 30 years of your age. But after 30 years of age, once the bone reach its limit, then it's going to be lost. Then it's going to be with age, after 30 years of age, it's going to be lost 1% every year, right? 1% every year. Okay, so again, the loss of this bone is again dependent on two of these things, right? If after 30 years of age, still you are exercising good, the loss is going to be really less. 1% is normal loss, right? Okay, but if you do not have proper exercise after 30 years of age, this bone loss is going to be, very like, you may have 2% of bone loss every year, right? If you do not have adequate exercise or physical activities. Similarly, intake of vitamin D is also really important, right? So if you're just taking a lot of vitamin D supplements after 30 years of age, so the decline in the bone is going to be really less. Okay, so these are the factors which are important for your bone growth and bone loss as well, right? Okay, another thing, if you remember, two things. We discussed that estrogen is dash to bone, protective or destructive?
Protective.
It's
It's
protective.
protective to bone. We
Increases
discussed
protection.
corticosteroids or glucocorticoids are based to bone.
Destructive.
They're destructive, yes, to your bone, right? So these are the factors which helps in bone growth or bone loss, right? So for example, if I have a young lady and then I have a lady after menopause, right? Post menopause. Young lady would be having good amount of estrogen. Post menopause will be having poor level of estrogen. In both of this individual or in both of these, like, these female, which female is going to be more vulnerable to get osteoporosis or get weakening of the bone?
Postmenopause.
Postmenopausal, because the protective role of those estrogen is basically lost, right? So osteoporosis is basically a reduction in trabecular bone mass, right? And really important thing about osteoporosis is that we do not discuss any other thing, right? So whenever someone is having osteoporosis, the labs are always going to be normal, right? Labs are always going to be normal, right? Because this osteoporosis process we discuss, it's nothing to do with your labs, right? It's something to do with your genetics, exercise, vitamin D supplements, right? So in case of osteoporosis, you won't be having disrupted wells, the values of your labs. Okay, so we discussed that if we have what are going to be the clinical features we're going to be having if someone gets osteoporosis, that is the destruction of trabecular bone mass. So he's going to, or he or she is going to have bone pain, easy fracture, especially where at the weight bearing areas, right? For example, at weight bearing areas, your vertebrae, I'm having a weak bone there, or loss of trabecular bone mass. It's obvious that it's going to lead to a lot of pain or fractures, kyphosis as well, bending of the ribs, right? Or sorry, bending of your vertebrae, right? At the hips, because they are also your weight bearing areas, distal radius, your weight bearing areas, right? So already the bone is getting weak there, and you are just that's a weight bearing area. Like you always just lift something with your hand, or you always, whenever you are standing, or you're just carrying out your own body weight. So these areas, the weight bearing areas, are going to experience a lot of force even at your normal activities, right? Is it clear? Hello.
Yes.
Okay, so in order to look for the
Yes, sir.
as we as we discussed that the trabecular bone mass is going to be lost, so the density of bone is going to be lost, like it's going to be very less dense. So in order to look for the density of bone, we use something called DEXA scan, right? DEXA scan is basically used to look for your the bone density. Okay, so as we discussed that the serum calcium is going to be fine, phosphate is going to be fine, PTH is going to be fine, alkaline phosphatase is going to be fine, right? Okay, because we discussed it's something to do with your normal, your weight, with your exercises, weight bearing exercises, vitamin D and genetics, right? So what is going to be the treatment for this? We discussed the treatment is going to be have a lot of exercise after 30 years of your age, right? Take a lot of vitamin D supplements, take a lot of calcium supplements in order to avoid bone loss. We discussed that, right? You can give something called bisphosphonates. We are going to discuss that in detail in our pharmacology section. But what are bisphosphonates? That's very simple. We know that here osteoclasts are functioning more, which is basically leading to loss of your trabecular bone mass, right? Because osteoblast is the one who is eating away your bone, making them really less dense, right? So we are going to give bisphosphonate, which are going to destroy your osteoclast. So if you do not have osteoclast, you do not have anyone which would destroy your bone. It can somehow help an individual with osteoporosis. Am I right? Hello?
Yes.
Yes, yes.
We can give estrogen replacement supplements, but it's like currently debated, right? Like some of the people think, or some of the scientists or some of the physician think that it won't give any help, while the other think that yes, it can help. This supplementation can help. Another thing, avoid glucocorticoids. Glucocorticoids, because we discussed glucocorticoids are destructive to your bone. Is it clear? So let me just give you a summary of osteoporosis. Okay, let me just give you a summary just from the beginning here, right? We discussed rickets, osteomalacia, rickets in children, osteomalacia in adults. Why? Less vitamin D. Less vitamin D, what would happen? Less calcium, less phosphate. less calcium and less phosphate, what would happen? Osteoid cannot become mineralized. Okay. Okay, how can we get less calcium? Okay, we know the normal calcium. Homeostasis says that from the sunlight we can get calcium, from the diet we can get calcium, 25 OH in the liver, 125 OH in your kidney. So if we have renal failure, again, it's going to lead to hypocalcemia, Trozu and Shostak sign with hypocalcemia, right? GI, we discussed that vitamin D in children. Okay, osteoid deposition in your frontal bone is going to give you frontal bossing, and the costochondral junction is going to give you rachitic rosy, small beads, spherical beads as structure, which are basically you have a lot of osteoid deposition. We discussed present-based deformity can be seen. Okay, bowing of the legs as we have osteoid that is really weak. Okay, then we discuss osteomalacia, we discuss the labs. Okay, for the osteoporosis, we discussed three things are really important: genetics, exercise, vitamin D supplements. Till 30 of year of your age, you are going to get that high peak bone mass. After that, 1% is lost, in every individual. In order to slow the loss process, still you have to do a lot of exercises. Along with that, you have to take some vitamin D supplements. Main important thing which we discuss here, the labs are going to be normal here, right? Estrogen is protective, glucocorticoids are destructive, right? So in postmenopausal women, she's going to be more vulnerable to have osteoporosis. Okay, let's discuss one of a pharmacological time, which we discussed in our renal section, right? It's going to be a revision, one of your dual MCQ. We have an individual, he has some kind of volume overload state, and we are going to give them diuretics, but that individual also is having osteoporosis. Which class of drug are we going to give? Loop diuretics or thiazide diuretics?
Thiazide.
Thiazide diuretic.
Because loop
Loop.
Perfect. Why? Because loop diuretics causes hypocalcemia, which won't be good for individual already having osteoporosis, right? Why? Thiazide diuretics, basically they are going to
Reabsorb the calcium.
reabsorb the calcium. Perfect. We discussed the entire process in our uh, hmm, renal section. So the next pathology which we are going to discuss is Paget disease of bone. Paget disease of bone. What happens in Paget disease of bone? That's really interesting, right? Okay, so let's just call it as Paget disease of bone, right? Paget disease of bone, because I think it would just help a lot. In Paget disease of bone, what happens? C stands for osteoclast here, right? Osteoclast. First of all, in Paget disease of bone, what happens? Osteoblastic activity increases a lot. So as the osteoclastic activity increases a lot, what would happen? It would just eat down a lot of bone. Am I right? As I'm increasing the osteoclast activity in Paget disease, it means the bone is going to be eaten with a, with a higher speed or with a higher velocity, because I'm increasing osteoclastic activity. Am I right? Hello?
Yes.
And osteoblast would be sitting there, and it would be only looking towards the osteoclast. That what happened to them there? Why are they just destroying the bone? So first of all, your osteoblast would just observe osteoclast eating a lot of your bone. Once osteoclast eats a lot of bone, then your osteoblast is going to become activated. Osteoblast would be thinking that, yeah, you have eaten a lot of bone, in a really less period of time. So osteoblast is then again going to lay down a lot of bone. But since it have really less time, osteoblast have really less time to lay down the bone again. So it would just lay down a bone, which is going to be really weak. Okay. Is it clear? So, hello? Hello?
Yes,
Let's
Yes.
read the story again. In Paget disease of bone, osteoclastic activity increases. It would just eat down your bone really fast. We don't know the reason. What's that? But it happens, right? Then your osteoblast would be sitting and looking towards osteoclast. What is he doing? Then osteoblast would again start laying down bone. So first of all, the first thing is osteoclastic activity would be high. The second thing would be mixed osteoblast and osteoclast activity. As your osteoblast is starting to lay down bones, still osteoclast would be working at that time, right? And the third step is only osteoblast working, because osteoclast would become exhausted, right? That just work a lot. That become exhausted. So we have three phases. First, the three steps or three different stages. First, osteoclastic activity, then mixed osteoblastic and osteoclastic. After that, your osteoclast will just become exhaust, and only osteoblasts are going to lay down bone. But osteoblast is going to lay down bone in a really fast way. So it's going to lay down bone which is going to be really weak. Is it clear? It's
Yes,
going to be really weak. So weak bone is, it's easy to fracture, right? It's easy to fracture this weak bone. Why? Because osteoblasts have laid down that bone in a really, in a really less period of time. So it only laid down osteoids and just a little bit calcified it, right? So it's going to be a really weak bone, right? So we are going to be having a thick sclerotic bone, but that would fracture easily. If you remember, we just discussed a pathology in which we are having thick but stone-like bone fracturing easily. What was that?
Osteopetrosis.
Yes, petrosis. And in osteopetrosis, what was the problem there?
Osteoclastic.
Osteoclast and
Failure of the
and
normal bone
defective
reaction.
osteoclast function.
Which enzyme?
Carbonic
Carbonic
anhydrase.
anhydrase.
Carbonic
Perfect.
anhydrase.
So we were not having a proper acidic environment there. That's why we were having, loss of the bone and osteoblasts were just working a lot, right? In this case, it's not due to carbonic anhydrase. It's due to increased osteoclastic and then osteoblastic enzyme, right? So we are going to be having microfractures. Why? Because osteoblasts have, laid down this bone, but it's really weak. The head size is going to increase because it's going to lay down a lot of osteoids. It's going to increase your head size. Hearing loss, again, in osteopetrosis. If you remembered, we were just laying down bone, which was just narrowing the lumen or the foramina from which your cranial nerves were exiting, right? Along with foramen magnum FL, if you guys remember, right? It was basically impingement of the cranial nerve due to, decreased lumen. Why the lumen decreases? Because we are going to be having a lot of osteoblastic activity. So same is the story here. Again, we are going to be having hearing loss, 8 cranial nerve loss, problem. Why? Because again, the foramina size are going to become really less, which is going to impinge your 8 cranial nerve, right? Similarly, we are going to be having loin-like faces, because if you have a lot of osteoblastic activity in the facial region, it's going to appear as a loin-like, right? And what will happen to alkaline phosphatase activity if you have a lot of osteoblastic activity in the end?
Increase.
It will increase.
So we'll be having isolated elevation of alkaline phosphatase. What is going to be the treatment? Yes, this I need you guys to tell me.
Bisphosphonates.
Bisphosphonates. Okay, so my question for you is that it's due to increase osteoblastic activity. So why are we giving bisphosphonate?
So osteoblastic activity is triggered by first destruction by
Perfect. The reason we are giving bisphosphonate is because the first stage which is triggering this entire pathology is your increased osteoclastic activity. It's a package disease for a reason, right? That's why if we just give bisphosphonate, we won't be having that initial stage of increased activity of your osteoclast. And in this way, we can just treat an individual with, a lot of bisphosphonate or decreased osteoclast activity. We can give calcitonin as well. Why? We discussed it in our endocrine. What's the function of calcitonin? It would just take calcium from the blood and deposit on the bones. Am I right? Opposite to PTH. Right? Hello?
Yes.
Yes.
Okay, so it would inhibit your osteoclast function. Okay. Another thing which you should just keep in mind, as we are just forming a lot of bone, here your osteoblasts are mad in the end because they have a lot of destruction done by your osteoclast to recover, right? They have to recover a lot of destruction. So they are going to make a lot of bone in a disorganized way. Bone have a lot of blood vessels as well. So sometimes due to formation of this bone, we can get AV shunts. What are your AV shunts? AV fistula. We discussed it in detail in our cardiology section. If we are having a lot of bone formation, can there be any chance of the arteries directly attaching to veins?
Yes.
which is your AV shunt. Whenever the arteries directly attached to the veins, it's going to give us AV shunt. Okay, so let me just ask you a question. If the arteries are directly attaching to the veins, what happens to afterload, total afterload?
Decreases.
Decrease.
Total after, why?
Because resistance decreases.
Because it's
Because
hitting the artery.
veins are really distendable, right? Veins have a lot of, they can just, they can accommodate a lot of blood, they are just like balloons. So what happens? The overall resistance is going to decrease if you are just joining arteries directly to your veins. So if the afterload increases, what would happen? Okay, afterload decreases. Well, okay, what will happen to the preload in this case?
Increase.
It will increase.
It will increase.
Preload would increase. Why? Because a lot of blood is basically flowing into the veins. Lot
Yeah.
of blood in the veins is going to push lot of blood into the heart as well, right?
Yes.
Yeah.
Yes.
Right. So if the afterload is decreasing, what would happen to the cardiac output?
Increase.
Increase. Okay. So let's discuss some cardiovascular concepts now, right? Okay. So if the cardiac output is increasing,
And
it means that, yes, please.
sorry, I have a question. Can you explain again the effect of calcitonin when you said in part of the treatment, aside from giving bisphosphonates, you can also give calcitonin? I didn't
Oh.
understand what you meant.
That's really simple. Calcitonin basically takes calcium from the blood and lay down it on the bone. Here we are getting a lot of osteoids, but less mineralization of osteoids. That's why the bones are weak.
Okay.
So if we give calcitonin, it can, calcify the bone. It can give us, a strengthened bone, which would be good for these individuals. And apart from that, calcitonin also inhibits your osteoclast function, right? Okay.
Mhm. Okay.
Okay.
But in the case of Paget's, right, isn't calcium normal? Like, do we have any calcium depletion in the case of Paget's disease?
In the case of Paget disease, the calcium is going to be, disrupted. It's not going to be normal, right? As we are destroying the bone, and then we are making the bone, right? So we need a lot of calcium for that still, right? Even if it's normal or if it's high, but still we need calcium in order to have the strengthened bone, right? Strengthen bone. So if you are just destroying a lot of, bone with a lot of osteoclastic activity, first of all, the calcium level is going to rise. Okay.
Okay.
Okay. Then we have missed osteoblastic and osteoclastic activity. Then basically the osteoblasts are going to, take these calcium in order to make bones. But as the osteoblast is going to make a lot of bone, a lot of osteoid, so this calcium is going to be, really less for, for that bone development, because not all of the calcium once come to blood can, go back again in formation of your bone. Some of it can be lost, right? So that's why calcitonin can be given in order to take this calcium and deposit on the bones again in the end phase of osteoblastic activity. Is it clear?
It is clear. It's clear. So, but I guess that's why I wanted to ask this question when you start talking about Paget's, because when I went through it, it says that both calcium phosphate are all normal in Paget's.
Okay.
So when you did explain that you have to still give calcitonin so that you have increased secretion of calcium, so that made me confused. That's why I asked.
Yes, but like if you are just looking towards the individual phases, the calcium there is going to be, high or low. But if you just look the overall, as we are just making calcium out, but still we have to put it again in to the bone in your osteoblastic, so they can just remain constant or a little bit decrease or increase, right?
Okay. So that would be because at the end of that's because so initially you have the increased activity of osteoclast, but at the end of the stage you now have osteoblasts.
Yes.
So in the calcium seemingly normal. Is that?
Yes. Okay.
Okay. Sounds
So we
yes.
were discussing, yes. Okay, thank you. So we were discussing AV shunts, right? We discussed that whenever, because we are just making a lot of bone in a really disorganized way, so we can have, a condition where the arteries can join with the veins. As we have arteries joining to the veins, what would happen to the afterload? You guys just told me that afterload would drop down. As the afterload drop down, we know from cardiac output increases. Okay. Preload would increase. Why? Because we have a lot of blood in the veins. So a lot of blood in the veins is going to push a lot of blood into the heart as well, right? So the preload again would increase, right? Hello? So the heart is going to deal with a lot of blood, because a lot of blood is flowing and a lot of blood is moving out as well, right? So by any time in your heart, you are going to be having a lot of blood. Am I right? Hello?
Yes.
It can lead to with heart failure, high output cardiac failure, right? Because your heart at this time is going to do a lot of work, having a lot of blood entering into the heart, a lot of it is going to be pushed out of the heart, right? There's a kind of volume overload state on your heart, which can lead to high output cardiac failure. Is it clear? Hello?
Yes.
Okay. Another thing which you should just keep in mind, as you can see that these bonds are breaking initially due to osteoclastic activity, and they are going to be forming as well in the end at your osteoblastic activity, right? So if I'm just making a lot of bone, destroying a lot of bone, making a lot of bone, destroying a lot of bone, can it get a kind of mutation in this process?
Yes.
No? Because
Yes.
we discuss how can a cell get mutated. There are a lot of causes of mutation, right? One of which is if you are, if you have highly turnover of the cell, right? It's a high turnover of the cell, right?
Yes,
We
doctor.
can get easy chances of getting mutation, right? So if we get mutation, mutation can lead to cancer formation as well, right? Hello?
Yes.
Yes.
So
That
we
is
can
correct.
have osteosarcoma. With Paget disease of bone, we can have increased risk of osteosarcoma. Why? Because there is a lot of bone turnover. You're destroying the bone, making the bone, destroying the bone, making the bone. So it can lead to, it can increase the chances of getting into osteosarcoma. Is it clear? Hello? Hello?
Yes, sir.
Yes.
Okay, perfect.
Yes.
Our next topic is avascular necrosis. We discussed avascular necrosis in detail once we were just doing the BNB slides, if you remember, right? So you guys are going to be telling me what is avascular necrosis, what are the risk factors, what can lead to avascular. Let me just pick someone. Okay. Mhm. Okay, anyone, any volunteer? Dr. Savera, can you just please tell us about avascular necrosis?
Yeah, sure. So avascular necrosis, it usually occurs due to different risk factors, including corticosteroids being the most common one, as well as trauma to the hip. They could have also
Perfect.
patients who are SLE patients, lupus patients, they can take
Okay.
corticosteroids and they can have this avascular necrosis of their femoral head,
Perfect.
as well as sickle cell patients can have this. So it's usually due to disruption of the medial circumflex artery, I think. Yeah.
Yes, it's going to be disrupted blood flow to the head of your femur. If the blood flow is disrupted, obviously it's going to lead to necrosis. That's avascular necrosis, right? Okay.
Yes.
So this
Yes.
was all about our pathology. Now we are going to discuss tumors. Okay. So tumors is going to be really easy topic, right? Okay. Whenever you see oma in end, that's going to be a benign tumor, right? Whenever you see, okay, sarcoma in the end of a tumor, that's going to be malignant, or carcinoma directly in the end of a name, it's going to be malignant tumor, right? Is it clear? Hello? So now I'll be writing down some tumors you guys are going to be telling me. Osteoma. Is it a benign or is it a malignant tumor?
Benign.
9.
Okay, perfect. It's going to be a benign tumor. What are going to be the features? It can grow on the facial bones. Really important, really high yield. You can have a UWorld MCQ on that, right? Associated with Gardner syndrome. We are going to discuss Gardner syndrome in detail in our GI section. But in Gardner syndrome, we can have a lot of polyps in the colon, right? Associated with the extra, colonic features can be osteoma growing on your facial bone, right? We're going to discuss it in detail, right? It's a really detailed topic in our GIT, right? Okay, so osteoma is, you guys just told me it's a benign. Most probably it would just, or be on your facial bones associated with Gardner syndrome, which we'll be discussing in detail, right? Another tumor is osteoid osteoma. What do you guys think? Is it a malignant tumor or a benign tumor?
It's a benign.
Benign.
It's a benign tumor. Osteoid osteoma. It means in this tumor we are going to be having osteoids, right? So osteoid, basically you can simply imagine that was a weak matrix, first of all formed by your osteoblast, and that matrix is then going to be calcified. Then you are going to get a mature bone. Am I right? Hello?
Yes.
So remember that weak matrix on your X-ray is going to be radiolucent. On imaging, it's going to be radiolucent because it's a matrix. You cannot just pick it, on your X-ray. It's going to be radiolucent. So osteoid osteoma. In osteoid osteoma, we are going to be having a benign tumor of osteoid, right? And this osteoid is going to be, surrounded by reactive bone surrounding this osteoid, and this reactive bone is basically called as osteoma. Is that clear? So we have a tumor, benign tumor of osteoid. We know what is osteoid. That's a matrix being laid by your osteoblast, which in future is going to become calcified in order to give you a proper mature strengthened bone. Osteoid osteoma is the surrounding bone, around that osteoid tumor. You are going to be having reactive bone, that is an overgrowth of bone just surrounding that, which is going to be called as osteoma, right? So it's osteoid osteoma. During imaging, this part is going to be radiolucent. You cannot see it on imaging, right? And you can just see this osteoma, that is the reactive bone surrounding this osteoid. Is it clear? Hello?
Yes, yes.
Yes, sir.
So you have osteoid osteoma. It's going to be tumor of young adults. Young adults below 25 years of age. In which part of the bone you can just see this tumor? In the cortex of the bone. Do you guys know what is the cortex of your bone? Okay, if it is your bone. Okay, first of all, what's the growth plate part of the bone? What's the name of this part?
Metaphysis.
Okay, metaphysis. What's the region above the metaphysis?
Epiphysis.
Epiphysis.
And what's this region?
Diaphysis.
Epiphysis.
Diaphysis. Okay, this strong outer layer of, you have periosteum, I guess, right? Around. So here beneath the periosteum, you have bone cortex, right? So it's going to be more probably seen in cortex of your bone, right? And on imaging, it would be always less than 2 centimeter and having a radiolucent core of osteoid. Is it clear? Hello? It's going to give you a lot of bone pain, but that bone pain can be controlled by aspirin. What is aspirin?
Consent.
NSAID.
It's an NSAID. It blocks, okay, it blocks COX, right?
COX pathway.
COX1 and COX2.
COX2.
Prostaglandins.
Low dose, it's going to block COX1 or in high dose? Remember, in low dose, it's going to block COX1. In high doses, it would just block your COX2, right? So we know that the COX1 and COX2, it can give us a lot of, thromboxane A2. It can be used as an antiplatelet as well. It can just give us some prostaglandins, which can basically, it is antipyretic as well. And it's also going to be used for some kind of pain as well.
Yeah.
This pain is going to be easily controlled by aspirin. We are going to discuss this entire details in our pharmacology, right? We're going to discuss it in pharmacology. But the bone pain here can be controlled with aspirin. We have another thing that's called osteoblastoma. Okay, what is osteoblastoma? Is it a malignant or a benign tumor?
Malignant.
Okay, it's going to be same as that of
Benign.
osteoma. Same as that of osteoma. Why? Because we know that the osteoid is basically made by your osteoblast, right? Am I right? So if you have
Yes.
osteoblastoma or if you have osteoid osteoma, both of them are going to be almost same. But what are going to be the differentials between both of them? If it's greater than 2 centimeter, it's going to be osteoblastoma, right? Okay. It would arise in the vertebra. Okay. And the pain cannot be controlled with aspirin. Is it clear?
Yes, it
These are the
is.
only differences between osteoblastoma and osteoid osteoma. Is it clear? Hello?
Although it is.
Yes, yes, sir.
Okay. Then you have osteochondroma. Osteochondroma. What does the name suggest? Is it a malignant tumor or okay, osteo mean bone? Chondroma means some kind of cartilage, right?
Yes.
Okay. Oma, is it benign or a malignant bone tumor?
Benign.
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 Benign bone tumor. Okay. So it's basically osteochondroma. It's basically tumor of a bone which is going to be surrounded by cartilage,
Yeah.
right? So osteochondroma, it's going to be benign tumor of bone surrounded by cartilage. And mainly it's going to arise from which part of your bone? It's going to arise from the metaphysis. Metaphysis, not epiphysis. There's only a single tumor which arises from epiphysis. That's a giant cell, right? We are going to giant tumor, which we'll be discussing, right? So metaphysis is going to arise from the metaphysis as a lateral projection. So this bone from the metaphysis is going to project laterally, and it's going to be surrounded by the cartilage, right? That's why we name it as osteochondroma. Is it clear? Hello? And this cartilage itself can sometimes lead to, a malignant cartilage tumor, which would be chondroma or chondrosarcoma.
That.
Chondrosarcoma.
If it's a malignant, it would be chondrosarcoma.
Mhm.
So, it's really bad. A tumor is getting a tumor, right? Tumor itself is getting a tumor, cancer of cancer, right? Okay. So, okay, same condition. If you guys remember cancer of cancer, if you guys remember a tumor, teratoma, remember? Hello? What was your teratoma? Do you guys remember what is teratoma?
Jump
Tumor. A lot of tissues. It can have even skin tissue. It can have even teeth, bones, everything, right? And sometimes the skin within this tumor can have a tumor, right? Can have a cancer. So it would be so bad if your tumor is getting it, right? Okay, so osteochondroma. Then we have our last tumor, which we are going to discuss today, is osteosarcoma. Is it a malignant tumor or a benign tumor? It's a malignant tumor of your bone. As we discussed, Paget disease can get you osteosarcoma. Remember, due to mutation going on, right?
Yes.
Hello?
Yes.
Radiation
Yes,
can do that. Radiations can also cause mutation of the bone, right? Mutation and can lead to cancer, right? Familial retinoblastoma can also lead to osteosarcoma, right? We're going to discuss familial retinoblastoma in details in our cancer, in our oncology module, right? Okay, so it's basically a benign tumor which arises from which part of the bone? Metaphysis. Is it clear? So it would basically arises from the metaphysis of long bone, usually the distal femur or proximal tibia, right? So at the region of knee, we are going to see it, right? Is it clear? Hello?
Yes.
Okay, there is a really characteristic feature of this tumor, which is really important, that is called sunburst appearance or Codman triangle, right? So it's really easy to know, right? So sometimes, like for example, if this is your bone surface, right? And if this tumor is growing like that, okay? So sometimes this tumor can have, like, on imaging, you can just see waves, just like a sunlight originating from this tumor, right? Which is called as sunburst appearance. Okay, sunburst appearance, right? And as the tumor is growing, it would lift this periosteum along with itself. Periosteum is the outer covering of the bone. Am I right? So if this is your bone, the tumor is going to lift this periosteum, from the bone, and it's going to make an angle here, right? A triangle. So this is basically called as Codman triangle. So sunburst appearance and Codman triangle is highly specific for which tumor? Osteosarcoma, right? Because it's a malignant, a highly aggressive tumor, it would appear as a sunburst, right? It would just try to move out just as a sun. It would just split to move out in every direction, giving you sunburst appearance. Once it's growing out, it would lift that periosteal layer from the bone, giving you a Codman triangle, making an angle, right? Is it clear? Hello? So the biopsy of this bone is going to give you pleomorphic cells that produce osteoids, right? So pleomorphic cells, we know that what are pleomorphic cells? That they are basically highly characteristics of any kind of malignant tumor, the pleomorphic cell, okay, which is indicating high mitotic activity, indicating an aggressive tumor, right? So it was all for today. Time is finished, and tomorrow we are going to finish this entire pathology, right? And day after tomorrow we are going to start physiology and pharmacology on the same day, right? So we are going to finish it within 3 to 4 days, and then again we are going to be having our assessment boot camp in the end, and just get prepared for the neurology, after this system. Okay. So thank you so much. Thank you. Hope so you guys enjoy it. Thank you and have a nice day.
Thank you so much, doctor.
Thank you.
Thank you. Thank you. Oh, wait. Hello, guys. Oh, no, wait, but no. Oh, Imagine, 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 IFCC. Hello, everyone. Oh, message करना मैंने बोली. कुठे आहे?
Paling dia pun baru. Ikai grup dia sendiri main pun. Iya datang kan. Iya tuh. Halo Max. Jangan itu. Oh yang berani, bawa aja bilang terus dan bawa tiang ini betul बढ़िया Oh, yang